Hello, everybody, and welcome to this fifth CEU of Christmas. Wow, that's a mouthful. I'm joined by Wendy Stevens. I'm Diane Cohen. Wendy, how are you?
Oh, I'm doing well, Diane. How are you today?
I am fantastic. Can you tell people who you are?
I'm Wendy Stevens, and I'm the regional manager up in Northern California, San Francisco Bay Area, and the East Bay. And I work for MacroPro and teach people a little bit about what we do and help them get the evidence that they need for the claims and the cases that they have.
Excellent. Well, and I'm Diane Cohen, Vice President of MacroPro, and I do the client services and run our educational department. So I'm certainly hoping that you're enjoying these 12 CEUs of Christmas that Wendy and I have put together for you. So before we get started, Wendy, we got a little bit of housekeeping. Maybe you can share some housekeeping.
We do. As you can see from what's on the screen, today's webinar is with one California continuing education unit. One of the things is you need to be logged on to go to webinar. If you've called in, we need you to go and log into the webinar. The thing with that is you are not able to be accounted for if you're not logged in because the GoToMeeting system cannot track you if you're just calling in. So that's one of the important things to know. Diane, you want to talk about the handout?
Yeah, we have handouts that are attached. And so we want you to download those now so that you have them for further reference in the future if you should need them. They'll have contact information for our speakers as well. So, in the future when you say, hey, I need to get that phone number from Howard or Gary, you'll have it at your fingertips. In addition to that, the CEU that Wendy was talking about, well, that's going to come to you in approximately 1 hour after this presentation. So make sure that you download it immediately. Go to webinar, keeps it on their system for about, I think it's 30 to 60 days. So after that, it won't be available. Make sure that you do download that. If you have any questions for our experts, please make sure that you put them into the question portion of the control console, and Wendy and I will be happy to ask that of our experts. And then lastly, if you would like to see our program again, it will be on YouTube. You can watch this and any other program. I would like to remind you when I say any other program, tomorrow we will be having our 6th CEU, and it's going to be on Medicare set-asides, and then our 7th, which is going to be on denials. So make sure that you watch our webinars for that. You can go to the MacroPro website and register for that program there. Hey, Wendy, why don't you take it over from here?
Okay, thank you, Diane, very much. Today, I'm going to introduce Howard Culkin. Howard is with the Center for Neuroskills, and Howard has brought to us an amazing speaker all the way from Texas. Apparently, they've just had a really bad cold front come in, but still we have our speaker. Howard, how are you today?
I'm fantastic, Wendy, thanks.
Oh, I'm good. Glad to hear that. Howard, can you tell me a little bit about what it is that you do for Center for Neuroskills?
I can. And by the way, we really appreciate being a part of the MacroPro and Friends 12 CEUs for Christmas. So thanks so much. I am the Regional Director of Payer Relations for CNS. And I work out of Northern California as well, not too far from you. So who is CNS, you might ask? Oh, you did. CNS, Center for Neuroskills, is a highly specialized post-acute brain injury rehabilitation program with facilities in Texas and California. We have 4 facilities in Texas and 3 in California.
Love to hear that, Howard. I think that's wonderful. So without further ado, would you like to introduce your speaker for today?
I would be honored to introduce the speaker today. Dr. Gary Seale is the Regional Director of Clinical Services for the Center for Neuroskills. He received his doctorate degree in rehabilitation science from the University of Texas Medical Branch, UTMB in Galveston, Texas. He is dual licensed in Texas as chemical dependency counselor and psychological associate with independent practice, and holds a clinical appointment at UTMB in the School of Health Professions, Department of Rehabilitation Science. He's worked exclusively in post-acute brain injury rehabilitation for over 30 years now, and has conducted research and published peer review articles on topics including rehabilitation outcomes, the relationship between positive emotion and recovery of functional status following stroke, and emergency preparedness for disabled populations. So after that mouthful, Dr. Seale, I'm going to turn it over to you, and it's all yours.
Great. Thank you, Howard, and welcome everyone. Thank you for being with us today, and happy holidays to everyone. It is dress up day at my facility, so I'm wearing Santa socks and a Santa hat. I forgot to take it off as we were broadcasting. So today we're going to talk about neurological consequences of COVID-19 and some practical treatment considerations that we put together in our clinics based on best practices that are published in the literature. We have a pretty full agenda today, so I want to try to get right to it. If I do my job, you should understand the ways that COVID-19 can cause neurological injury and a number of the symptoms associated with COVID-19. We're going to talk about long COVID and risk factors for developing long COVID, as well as some treatment interventions specific to this disease package. We also want to discuss the importance of individualized and integrated treatment. There are no two patients that present in exactly the same way, and we found that the symptoms are varied enough that we treat with at least 3 disciplines, and so we'll talk about how that treatment modality and approach can be effective. Having a little trouble with advancing my slides. So COVID-19 related neurological injury is an acquired brain injury, not a traumatic injury. And I want to spend a little time just introducing and reviewing some of the statistics associated with brain injury. To kick off, traumatic brain injury is a major public health problem in not only the United States, but worldwide. In the US, TBI occurs about every 15 to 22 seconds, resulting in somewhere between 1.7 and 2.5 million injuries each year. While the majority of those injuries are mild in nature, still about 300,000 people are injured to the degree that they need hospitalization. About 100,000 people each year develop a disability stemming from a traumatic brain injury, and TBI remains leading killer and disabler of young adults under the age of 35. About 2 decades ago, falls overtook motor vehicle accidents as a primary cause of traumatic brain injury, primarily because of our aging population. The segment of the population 65 years and older is the fastest growing segment of the US population, and the subset of 85 and older is the fastest growing group of people in that elderly 65 plus range. About 6 million Americans today live with a disability stemming from a traumatic brain injury. In terms of acquired brain injury, stroke is another leading cause of brain injury. There are about 800,000 strokes that occur each year. About 500,000 are first onset. About 300,000 are recurrent strokes, and under that umbrella, diagnosis of stroke or aneurysms, AVMs, TIAs, other diagnostic categories. You'll see an asterisk by stroke because stroke is a neurological consequence of COVID-19. COVID-19 causes blood clotting disorders, and therefore people wind up with blood clots that wind up in the brain or the lung. There are also injuries associated with anoxic and hypoxic events. This can occur because of a near drowning, an electrocution, a heart attack. Because COVID-19 attacks the respiratory system, and because people often develop pneumonia requiring intubation, anoxic and hypoxic events are associated with COVID-19. Finally, COVID-19 also irritates and inflames the linings of blood vessels throughout the body, including the brain. And so encephalitis is a third neurological consequence of COVID-19. We'll talk about these in more detail as we progress through the presentation. If you compare acquired brain injuries, all acquired brain injuries, about 3.5 million cases a year, with the annual incidence of other leading injuries and diseases, you can see that those other causes of injury and disease pale in comparison with the numbers of acquired brain injuries. However, disease processes and injuries like various cancers, HIV/AIDS, spinal cord injury, tend to get a lot more press, greater access to care, and more research dollars spent on cures than we see with brain injury. There are a number of risk factors associated with acquired brain injury. Age is a risk factor for both TBI and stroke. In terms of traumatic brain injury, there is a trimodal distribution. The very young, birth to 4, are at high risk, unfortunately, due to parental abuse, falls, and automobile accidents. The young adults, 15 to 24, are at high risk, primarily from sports-related injuries and automobile accidents. And as I mentioned earlier, the elderly, 65 and above, are at high risk due to falls. Age is also a risk factor for stroke. Most people experience their first stroke in their 5th decade, and the risk factor for stroke, or the risk for stroke, increases twofold every decade thereafter. Lifestyle choices are associated, or is a risk factor with both TBI and stroke as well. A risky lifestyle, drinking and driving, those kind of things are associated with TBI, while heavy tobacco, alcohol use, being overweight, a high-fat diet, a lack of exercise, all those lifestyle choices are associated with stroke. Substance use and abuse, again, a risk factor for both TBI and stroke. John Corrigan and Jennifer Bogner have done most of the work in this area using TBI model systems data and found that about 66% of individuals who present at an emergency room with a traumatic brain injury are under the influence of drugs and or alcohol at the time of injury. Some of their samples were as high as 78%. Chronic alcohol misuse is also a risk factor for stroke. Chronic alcohol misuse can cause clotting factor disorders, can cause heart arrhythmias, is associated with diabetes and hypertension, and all of those are risk factors for stroke. Learning disabilities, psychiatric disorders, prior brain injuries, these conditions are associated with impulsivity, poor decision-making, and problem-solving, and tend to set a person up for a brain injury. But the biggest risk factor for sustaining a traumatic brain injury is being a guy, because guys do stupid stuff, and young guys do real stupid things. I don't know if you can appreciate what's happening in this picture, but this gentleman has propped up his truck with a couple of 4x4s, and he's welding his drive shaft back in place. So this is a TBI and a spinal cord injury looking for a place to happen. There are a number of consequences associated with acquired brain injury. There are motor and sensory consequences. For example, the motor and sensory pathways cross in the brain. So someone who receives a right hemisphere injury, for example, could have motor and sensory changes on the left side of the body. Anything motor changes can involve decreased strength, lack of coordination, all the way to a flaccid extremity. The same with changes in sensation. There can be a misinterpretation of sensation, some tingling, all the way to a numb, if you will, extremity. Communication deficits following brain injury, left hemisphere injuries tend to be associated with aphasia, difficulty appreciating, interpreting the spoken and written word. Right hemisphere injuries tend to be associated with the nonverbal aspects of language, impairments in the ability to appreciate humor, sarcasm, the melodic properties of our voice, interpreting facial expression and gesture. Emotional consequences include anxiety and depression. In fact, the literature informs us that individuals who have moderate to severe brain injury will experience clinically significant levels of anxiety and depression, usually within the first year of injury. Left hemisphere injuries tend to be associated with depression, whereas right hemisphere injuries tend to be associated with emotional lability. And finally, cognitive deficits can include attention, memory, and executive dysfunction. All of these combine to impair psychosocial outcomes. That is, the ability to engage in meaningful daily activities and fulfill significant societal roles. And motor, sensory, emotional, and cognitive consequences are particularly those domains that are associated with COVID-19 related neurological injury, and we'll talk about that in more detail in just a bit. I want to focus on some medical complications as well, because this is particularly relevant to our topic today. About a decade ago, Brett Maisel and Doug DeWitt published an article in Neurotrauma entitled Brain Injury, a Disease Process, Not an Event. And it was their position that for some people, brain injury is the beginning of a chronic disease process, and that brain injury can be disease causative and also disease accelerative. And they list a number of facts about brain injury and medical complications in their article, including people with brain injury are more likely to develop seizure disorders. The general population reports, about 5% of the general population reports sleep disorder. However, the brain injury, people with brain injuries, about 30 to 35% report sleep disorder, including sleep apnea, periodic leg movement, and daytime hypersomnolence. Similarly, about 30% of the brain injured population report or demonstrate neuroendocrine disorders, including decreases in sex hormone, decrease in human growth hormone, and also hypopituitarism. We've already talked about anxiety, depression, substance misuse, but people with brain injury also demonstrate what's been termed a metabolic dysfunction, and that is they process foods differently than their non-injured counterparts, having difficulty processing some amino acids, and this may lead to or be a part of the physical and cognitive decline that we see over time. But what I want to focus on primarily are changes to the immune system. Individuals with brain injury tend to have compromised immune system. They are more at risk for infection, and they are particularly vulnerable to respiratory infection and pneumonia. And if you recall, when COVID-19 was introduced in late 2019, early 2020, we found that people who had compromised immune systems, who had compromised lung function, who had certain comorbidities, for example, diabetes, hypertension, obesity, were particularly vulnerable to the virus. So the brain injury population, again, having decreased immune function, being particularly vulnerable to infections, particularly respiratory infections, and having a number of these comorbidities, were among the most vulnerable to acquire the virus. And so in March of 2020, if you recall, stay-at-home orders were issued. We were gonna stay at home for 2 weeks to flatten the curve, if you remember, or slow the spread. And our patients, again, they were protected by staying home. However, they were also vulnerable for functional decline, isolation, and depression because they were not engaged in an active treatment program. So we had a dilemma, those of us that work in the field of brain injury rehabilitation. How do we protect our population from the virus, yet provide them with the treatment they need to prevent regression, isolation, depression, and the development of some comorbidities that are unwanted? And so many programs, CNS included, pivoted very quickly to telerehabilitation. And we were successful in that approach. In fact, in 2020, the Center for Neuroskills facilities delivered over 125,000 hours of skilled therapy to our patient population. We have analyzed and published those data, and I'll let you know that that is a CEU that is available if you'd like us to come back and talk about that at another time. So the COVID-19 or severe acute respiratory syndrome coronavirus 2, say that real fast 5 times. We learned early on that it was a respiratory pathogen that could lead to respiratory distress, decreased oxygen saturations. It was also associated with high prevalence of pneumonia requiring intubation and hospitalization. So we knew that early on. What we found out later was that coronavirus is also associated with neurological complications. People who contracted the virus also demonstrated confusion, high risk of stroke associated with coronavirus, as well as neuromuscular disorders, pain, muscle fatigue, joint pain and inflammation, and a number of additional neurological consequences. This is due primarily due to the fact that coronavirus is associated with clotting factor disorders. So blood clots would form and end up in the lung or the brain, causing a stroke. And the coronavirus also irritated the internal lining of blood vessels throughout the body, causing inflammation and again, restricting blood flow in a number of organs and organ systems. Excuse me, I'm having trouble again advancing my slides. There we go. So as of June 15th, when I put this talk together, 85 million cases of COVID-19 have been reported in the U.S. That's a lot of cases. Clearly, more have been reported in the last 6 months. But this is the interesting statistic that between 10 and 20% of people who had COVID-19 went on to develop lasting symptoms or long COVID. So that's somewhere between 10 and 20 million people with long COVID. And in surveys that were conducted, those who developed long COVID, 80% of those individuals reported cognitive deficits, primarily attention, memory impairment, and executive dysfunction. Also, people who were surveyed reported that cognitive deficits and mental health issues, primarily again anxiety and depression, were top of their concern list. So let's talk about long COVID and look at the definition there. So long COVID is described as symptoms that either persist, symptoms that were noticed during the active infection that never went away. So fatigue, sleep disorder, headache, difficulty breathing, loss of taste and smell, those would persist. Or people would appear to recover and symptoms would return after a period of time, or a new symptom package would appear. And these would either persist after 4 weeks of active infection, or they would present about greater than 4 weeks after the active infection. And so if symptoms persisted for more than 12 weeks and could not be associated with another condition, the term post-COVID syndrome was offered. Again, my apologies for technical difficulties here. So long COVID was so prevalent that in June of 2021, the American Medical Association in a special meeting adopted support for the development of ICD-10 codes for long COVID and associated symptom packages. And as of July 2021, long COVID or post-COVID syndrome can be considered a disability under the Americans with Disability Act, because so many people had difficulty resuming normal activities, returning to work, and if they did return to work, oftentimes they were asking for accommodations. So who's likely to develop long COVID, and who might be at risk for these neurological consequences of COVID-19? So there's a group that's pretty intuitive, pretty obvious that these folks were at risk for long COVID. There's a second cohort that it's a little confusing still why these folks are susceptible or at risk for long COVID. So obviously, people who had more severe COVID symptoms, who were hospitalized for long periods of time, individuals who were over 65 and had underlying health conditions, particularly obesity and diabetes were at high risk. People with disabilities, this includes the brain injury population, again, because of compromised immune systems and risk for developing infections, particularly respiratory infections, and the unvaccinated. So those are obvious groups that were at risk for long COVID. What surprised us was that there were some people who had no symptoms associated with when they tested positive for COVID, or mild symptoms, never hospitalized. A number of those individuals developed long COVID, as did people who were well under 65, healthy and active prior to the onset of COVID symptoms. And females tended to be to acquire long COVID or develop long COVID more often than males. So how does COVID-19 affect brain function? Well, we think that it's an airborne respiratory virus, so it's likely that the virus enters by the nasal passages and reaches going through the sinuses to the olfactory bulb, and then travels along the olfactory nerve to affect other areas of the brain. When the virus enters the system, it triggers an inflammatory response, and cytokines are proteins that are released as part of the immune response to infection. But with COVID-19, this inflammatory response was excessive and uncontrolled. It was called cytokine storming. And this inflammatory response often interfered with the ability of neurons and neural networks to communicate, causing brain dysfunction and ongoing damage. Obviously, pre-COVID, poor heart and lung function could lead to hypoxia, which was just exacerbated by COVID-19. And then there were brain consequences or brain function consequences associated with treating COVID-19, particularly in ICU, where folks are medicated, sedated, and intubated for long periods of time. This is also associated with decreased cognitive function. Some of the common neurological consequences of COVID-19 included impaired concentration, headache, sensory disturbance, including primarily taste and smell. We've already talked about mood disorders, primarily anxiety and depression. People had difficulty sleeping, severe fatigue, and what people describe as brain fog. But really no organ system was spared in response to COVID. Again, thinking about the fact that COVID caused clotting factor disorders and inflammation inside the lining of blood vessels. These blood vessels carry oxygen and nutrients to every organ and every organ system in the body. We saw symptoms associated with multiple organ systems. Again, the primary symptom package included fatigue, some cognitive consequences like poor attention concentration and decreased memory, also shortness of breath and chest tightness. But in addition to those, people reported decreased appetite and weight loss. Sometimes this was due to, again, loss of taste and smell. Food didn't taste good or tasted bland. But people reported abdominal pain and nausea associated with COVID-19. There was reports of joint and muscle pain, as well as numbness and tingling, particularly in the extremities, skin rashes and hair loss, and heart palpitations. So again, wide variety of symptoms. In fact, we rarely saw two patients that presented with the same symptom package in our clinics. Researchers, in trying to categorize long COVID, developed sort of three categories or buckets. There were those folks who had neurological consequences due to cell damage in multiple organs caused by the virus itself. Then there were those who had problems associated with chronic hospitalization. These either caused neurological symptoms or exacerbated neurological symptoms from the infection. So people that were in the hospital, intubated and bedbound for weeks or months, had muscle weakness, fatigue, cognitive dysfunction. And then we'll talk a little bit later about a post-ICU syndrome, which looks a lot like PTSD, And these were folks that were in the ICU for extended periods of time. And then finally, there were folks who appeared to recover from COVID-19. Again, they were exposed. 5 to 7 days later, they began to show symptoms. The symptoms persisted for 3 or 4 weeks, and then waned, and the person appeared to recover, only to have symptoms either reoccur or a new set of symptoms present greater than 4 weeks after apparent recovery from COVID. So again, the effects of COVID can last, the duration varies from weeks to months. Some folks experience symptoms for as long as a year, and the reported symptoms vary widely. So it required modifications in our general rehabilitation approach. Because the variation was so wide and the symptoms reported were so varied, again, a very individualized approach was necessary. And so we found ourselves during the assessment period asking some different questions of our patients so that we could target the symptoms that were most troublesome, put together an individualized treatment plan, and identify some outcomes that were relevant and important to the patient. So we would often ask, what aspects of your condition affect you the most? Is it the fatigue? Is it the decreased endurance and problems catching your breath, getting feeling out of breath just going to the mailbox and back? Or what are you hoping to get back to? And people would often say, well, I want to get back to working out. I can't go to the gym because I'm so fatigued and out of breath. Or I want to go back to work, but I have this pain and I can't sleep at night. Or finally, we would ask, if you didn't have these symptoms, what would you be doing today? And they would, again, tell us what their preferred activities would be. And so all these became targets for intervention. We also found that because the symptom reporting was so varied, that we had to undertake an interdisciplinary approach headed up by a case manager, because not only did someone need to coordinate the therapies for these people, they were also connected to a number of medical specialties. So in addition to having a primary care physician, maybe now, because of their response to COVID, they had a cardiologist that they were engaged with, or a pulmonologist that they were engaged with, or someone in internal medicine. So all this had to be coordinated. So physical therapy focused again on fatigue, strengthening, improving endurance, and addressing joint and muscle pain. Counseling, we found, it was a huge player in our interdisciplinary team, and I want to share a lot of the interventions in a moment that counseling used. But counseling in concert with physical therapy and nursing would address pain. Counseling would address anxiety and depression that were the primary complaints, as well as poor sleep and the PTSD symptoms associated with long or prolonged ICU treatment. Occupational therapy was important in establishing or reestablishing positive daily routines. People who were in the hospital for a long period of time had their routines disturbed. And so reestablishing that routine, making the world predictable, sort of settled them down physiologically. They were also instrumental in helping people learn about anti-inflammatory diets, because COVID-19 produced an out-of-control inflammatory response. Eating your way to health was another way to address COVID-19, or response to COVID-19. Obviously, speech-language pathologists, cognitive rehabilitation specialists would work on the cognitive consequences, and nursing was there for medication management and other symptom management. So in terms of physical therapy, really not a lot of variation from best practices or practice guidelines when it came to strengthening, balance and gait training, endurance training, and treating muscle and joint pain. However, fatigue management was something that required some creativity, right? So folks came to us so fatigued and so deconditioned that pacing and taking breaks in the therapy session or during the therapy day was necessary. working with a patient to determine when their energy levels were high and would support high intensity activities. So timing activities, physical activities during those best hours, encouraging patients not to stop, but to increase gradually. Our patients refer to PT as pain and torture. It's hard work. It's not for sissies. But if you stop, you regress. So we had to encourage patients often to not stop, push through, and gradually increase. And oftentimes our counselors would do co-therapy sessions in PT to encourage people to stay after it. And then we would add in some extra cardio sessions, and we were watching for that postural orthostatic tachycardia syndrome. This was particularly prevalent, a particularly prevalent symptom of COVID-19. People would stand and would feel lightheaded, dizzy, and their hearts would race. And so treatment involved educating patients and encouraging them to monitor salt and fluid intakes. There are medications that can treat POTS, primarily beta blockers and steroids, but that was not our first line of treatment. We tried, as a matter of fact, to decrease as many medications as we could. And then, wearing compression garments is also helpful. But just if you're a physical therapist and you're treating COVID-19 related neurological conditions, POTS is something to look out for. As I mentioned earlier, counseling has been a huge part of our treatment approach. Effective techniques included trauma-based therapies, particularly for those ICU-related PTSD symptoms, cognitive behavioral therapy techniques to treat anxiety and to help patients establish new behavior, acceptance and commitment therapy for dealing with uncertainty, as were these adaptive or approach-oriented coping strategies. People were very anxious, very frustrated. COVID symptoms lasted a long time, disrupted daily routines. People were uncertain if they were going to be able to go back to work or do the things that they enjoyed doing. So it produced a lot of anxiety. And then positive psychology practices to address depressed mood and keep people motivated for rehabilitation. So in terms of treating anxiety, our therapy staff worked on relaxation techniques through mindfulness, breathing exercises, and visual imagery. Mindfulness was particularly well received by our patient population. Again, it's just using sensory experiences to stay in the moment. Just a quick example of one of the techniques. This may sound a little odd, but I suggest you try it if you don't have a mindfulness practice. But we would give each of our patients a raisin and ask them to examine the raisin visually, look at it, look at its texture, see if they could find where it was originally attached to the vine. We would ask them then to put it in their mouth and roll it around the inside of their mouth with their tongue, experiencing again the texture of the raisin. We would ask them then to bite the raisin but don't chew it, experiencing that burst of sweetness in the mouth, so on and so forth. And so the idea is to have the patient focus on those sensory experiences, which keeps them grounded in the present. They can't worry about the past. They can't be anxious about the future. And there are a lot of ways to do this. We also did some outdoor mindfulness, walking, enjoying nature. Lots of ways to stay focused in the present. Those positive psychology practices, again, gratitude list is a powerful therapeutic intervention. We also ask patients to engage in 3 good things, where they write down or state 3 good things that have happened during the day, and then we wrap back around a little later and say, what was your part in that? What did you do to make those good things happen as a way to build self-efficacy? They would also complete a bad exercise. It's just a page with 3 columns. People would list what they're grateful for, their lifetime achievements, large and small, and their talents or good things they think people might say about them. It was an ongoing list they would add to week by week. And again, when things were tough or they felt down, we would ask them to refer to their bat list. Our therapists were intentional about starting and ending every therapy session on a positive, encouraging where they could patients to help others, because if you are engaged with someone else who is suffering, you're not thinking about your own suffering. Also, in a controlled environment, doing some downward comparisons rather than thinking, I wish I had a bigger house. I'm glad I'm not homeless. And similar kinds of activities, again, to reframe where people are and how they're thinking. Engaging in positive or approach-oriented coping versus negative coping. So negative coping involves, withdrawal, denial, blaming, substance misuse to escape reality. Positive or problem-focused or approach-oriented strategies include dealing directly with the situation by obtaining information, learning what you can do personally to take charge and control the things you can control, asking for help and assistance, altering the environment, also reappraising the situation as positive. This condition that I'm experiencing sucks, but what can I learn from it? What is the universe trying to teach me here? How can I come out better on the other side? We also address a common complaint after long-term hospitalization about filling in gaps or dealing with blank spaces. This is, again, not new to brain injury rehabilitation. Many of our patients with traumatic brain injuries report retrograde and anterograde amnesia around the accident. They really can't remember what was going on just before their accident, and they have no memory of events for days or weeks after their accident. But this is a little different complaint. Folks are intubated, they're in the hospital, they're heavily sedated. They come out of it and they've lost a period of time, weeks or months. And so they're very anxious about that, and they want to know, what's happened. So family sharing information from their diaries, looking at medical records and helping the patient understand how they have progressed and how they're healing and recovering, using newspaper articles, YouTube videos to bring the person up to speed. Here's what was happening in the world when you went into the hospital, and here's what's transpired in the interim, and here's where we are today. And then finally, using trauma-based therapies to help people overcome the post-intensive care syndrome that looks, again, very much like PTSD. We also try to encourage people to maintain a proper perspective. I like this Mark Twain quote. I've been through some terrible times in my life, a few of which actually happened. We tend to worry about the future, but research shows us that about 90% of the things we worry about actually never happen. And so when people come out of the hospital and they're recovering from COVID-19, they're worried or anxious about a lot of things. Unfortunately, those negative emotional states trigger the fight or flight response, which limits our response repertoire to running, hiding, freezing, and fighting, and impairs our judgment and our ability to engage the brain to collaborate and to positively problem solve. And so we try to help patients maintain a proper perspective. And then finally, we want to build resilience and self-efficacy. We want patients to be able to approach difficult tasks with confidence, to foster interest and curiosity about, how this activity is going to benefit me and help me recover, and help them maintain motivation to sustain effort. People who approach difficult tasks, who are curious about them, who sustain effort, do much, much better. Their outcomes are much better than folks who shy away from a challenge, who dwell on the negatives or personal deficiencies, who give up quickly. Those folks tend to not have robust outcomes and again tend to remain incapacitated or disabled. So again, we want to build in self-efficacy and resilience. So just to recap, though, that's a lot. Again, counseling had a big role in our interdisciplinary approach. So again, helping patients focus on the things they can control, stay in the present, maintain that proper perspective, engage in positive psychology practices to address depressed mood, stay connected, ask for help, and then engage in those resilience practices that promote efficacy. So moving on to the cognitive consequences of COVID-19. Again, we talked about we talked about attention, memory and executive dysfunction being the primary symptoms reported with COVID-19. And so cognition, obviously, are those mental activities like attention, perception, language that help us organize information and use it to function efficiently in our environment. And when we encounter a cognitive deficit, we want to come at it with a systematic and hierarchical approach that allows patients to relearn, to attend to, select, remember, and apply information appropriately in response to the environment so they can function as efficiently and independently as possible. And so cognitive rehabilitation, again, is carried out as part of an interdisciplinary program. The therapy techniques are individualized and are geared to bring about change that impacts daily function and promotes community integration. And generally, there are two approaches that we use in tandem. We don't use one or the other. So some of our interventions are trying to restore cognitive function by reestablishing or strengthening a particular skill or process, and then there are the external or compensatory strategies that are there to help a person get around a particular deficit. It involves assessing the kinds and limits of learning, identifying deficiencies, and developing interventions to strengthen those deficiencies and repeating those in a controlled environment until they're mastered, and then taking it out into the community to ensure that those skills that are learned and those compensatory strategies that are mastered are able to generalize to the discharge environment. We begin in a quiet environment and we move to more distracting environments, either stimulating those in a clinic or taking people out into busy environments in the community. We start with simple tasks and move to more complex tasks, and we start with concrete concepts moving toward more abstract. So again, it is a hierarchical approach to rehabilitation. Same with our compensatory strategies. Again, by definition, a compensatory strategy is equivalent to, and it is there to neutralize the effect, offset the undesired effect of, again, an attention problem, memory problem. They may take a little bit more time to master, and they're not as efficient as the original response, but they get us to the same place. And I love Gary Larson, and I hope no one is offended by this example, but a simple checklist can help people be independent. So first your pants, then your shoes. Again, this person using that checklist can dress himself and not be dependent upon a family member or an attendant. Some additional principles, again, we've talked about the hierarchical organization of the interventions. We want to provide consistency, repetition, and structure to promote positive neuroplasticity. We always want to be flexible and adapt to the needs and goals of the patient, and we're always thinking about how to facilitate generalization to the discharge community. We also, again, want to make sure that when we engage patients in cognitive activities that they are at their best. So we don't want to do it at a time when they're fatigued or sleepy. Every medication has a side effect, and the medications our patients are on to address pain, spasticity, seizure disorders, mood disorders, those side effects can cause cognitive clouding. So if we can remove people from medications or decrease medications effectively, we want to do that. Or if we can't, if it's not, if that's medically contraindicated, we want to dose them at a time when the side effects are not going to interfere with their therapy. In terms of approaching attention and memory deficits, we use a three-stage approach that is considered best practice. So in the acquisition phase, we teach the patient about the strategy and how it's going to be used and how it will help them achieve their goal. Then we practice that in the application phase in a controlled environment until it's mastered. And then we go out into the community or in other environments to make sure it generalizes. And we're talking about association techniques, first letter mnemonics, organizational strategies. And so just a quick example, because I don't want to take up too much time. To remember names, we may use an association technique. So I would tell a patient, I'm going to teach you this technique so that you can remember names. And what I want you to do is focus on a prominent facial feature of my face and associate with my name. So if you look at my face, I have a beard. A beard is hairy. Hairy rhymes with Gary. My name is Gary. What's my name? So we'll do these association techniques until this person masters my name. Then we'll go look for others in the clinic, and we'll apply this association technique to remember names, and then we'll take it out in the community. So just a quick example about what that might look like. In terms of executive dysfunction, planning and sequencing deficits, time management deficits, and functional problem solving were among the most frequent complaints of our patients. So planning deficits, we often address that through planning, detailed planning sheets. Where are you going to go? What are you going to do? How much is it going to cost? How are you going to get there and back? And did you enjoy the activity? Sequencing deficits, we use detailed checklists, almost like a prescription or a recipe. And then for time management deficits, we did a lot of time estimation and prediction. How long is it going to take you to do this? We set a timer, and if there was a big discrepancy between what was predicted and what we saw, we would address that. Sometimes just using planning sheets and sequencing sequencing checklists would help deal with time management deficits. We also taught patients a 4-step problem-solving model that was originally developed by Hugh de Vigny almost 50 years ago, and is still relevant today. Again, we would engage in these cognitive rehabilitation practices, providing structure, repetition, and consistency in order to promote positive neuroplasticity. We know that the brain responds to stimulation, and when we stimulate the brain, experience-dependent learning causes changes at the synaptic level all the way up to complex neural pathways. And we use that, we harness that to maximize rehabilitation. In fact, research has shown without these experience-dependent changes, substantial recovery is probably not likely. Another target was sleep disturbance. We talked about in the general population, about 5% of the people report sleep disturbance. In the brain injury population, it's more than 30%. And with people who had COVID-19, it's even higher than that, because quarantines, lockdowns, just disrupted people's circadian rhythm. They had trouble going to sleep and staying asleep. And so we know that sleep deprivation in the general population is associated with all kinds of comorbidities that are dangerous. So again, we've already talked about sleep disturbance upsetting our circadian rhythm. Anxiety, depression, impaired cognition are associated with sleep disorder, as is hypertension, diabetes, and certain cancers. What is really surprising about these statistics is that about 60 million Americans report chronic sleep problems, and this is the general population. And nearly 40% of adults report falling asleep during the day without meaning to at least once a month. So sleep disorder is a huge issue in the general population. It's certainly a big problem in people with brain injury and COVID-related neurological injury. So we spent a lot of time working on developing sleep hygiene protocols for individuals, encouraging them to develop with us a routine and practice it at home, turning off electronics and TVs at least 30 minutes before bedtime, beginning to dim the lights, keeping the room at a cool temperature. And the ideal temperature for sleeping is 69 degrees. Sometimes that's a little hard to achieve here in Southeast Texas. If you're a person that wakes up during the night and looks at the clock, turn the clock face away, use a relaxation technique, and make sure you only use your bed for sleep and sex. That's it. Don't eat in it. Don't watch TV in it. Don't do puzzles in it. Sleep and sex. That's all you get to do in your bed. And then finally, our occupational therapy department worked really hard, again, on reestablishing these positive daily routines. When people are outside of their routine, they become anxious. And when they become anxious, it affects them physiologically in terms of their heart rate, body temperature regulation, sleep-wake cycle. So reestablishing a positive daily routine is extremely helpful in stabilizing people physiologically. And finally, teaching people to eat an anti-inflammatory diet is a natural way to address some of the problems associated with COVID-19. So, omega-3s, lots of lean meats, and some supplementation where necessary. And then lastly, we always sent patients home with what we call therapeutic home programs, or THP, so that they could practice all these things at home. That helps extend the therapy day. It keeps them engaged. They progress faster, and it helps maintain the durability of our outcomes. So again, in summary, COVID-19 can cause neurological symptoms. They're varied and can be brief or long-lasting. It requires a multidisciplinary and individualized treatment approach, and we should continue to encourage patients to work at home on their own. There's a ton of literature out there. I know COVID has only been around, or this variant of COVID has only been around for a couple of years, but there's a burgeoning set of literature. It's very informative, so I encourage you to read more about it. And with that, I will open it up for any questions.
Well, Gary, we don't have any questions currently, but you covered so much material. It's unbelievable, all the consequences there are because of COVID. And I feel so badly for those who can't sleep, because sleep is such an important part of our life.
Yes.
So
Diane, I just wanted to let you know, if people do have questions or think of something later on, feel free to share my email address with them, and I will get back to them with a response, or I can put them in touch with somebody who knows if I don't know. We're happy to help people find information.
Well, Gary, why don't you give it to them now so they can write it down?
Okay, it's my first initial G, my last name Seale, S-E-A-L-E, so G Seale at neuroskills, all one word, .com.
Excellent. Well, at this point, I'm going to ask if there's any closing comments that Howard and Wendy may have.
Yeah, I just, the closing thought that I have for everybody is, with the flu and RSV and COVID and everything going around, I just wish everybody a healthy new year more than anything else. Obviously safe and happy, but healthy is the most important. So wish you all that for the new year.
Thank you, Howard. I would like to sort of echo what Howard just said, wishing everybody a happy and warm and safe holiday with family and friends, and wishing you all the best of joy and peace and prosperity in the new year.
Excellent. Doctor?
Yeah, wash your hands, take your vitamins, make sure you eat well, sleep well, and move. Get out and move during the holiday season.
Well, I'm certainly looking forward to the day that COVID is not part of our everyday vernacular, and that, our friends and family are no longer catching it. I would like to remind everybody, if you do need records, so that Gary or anybody else can review them, we would like to make sure that you remember to call on MacroPro. And Gary, I love that.
Be nice.
Yeah, I love it. You went from naughty to nice. Excellent. Well, everybody, have a happy holiday season. Again, we'll see you tomorrow for 2 more 12 days of Christmas CEUs. Bye-bye now.
Thank you.
Thank you.